All right, and that's time. That was a quick hour. It was a full 60 minutes. Can everyone hear me still? Awesome. All right, well, welcome to some of you who joined at 7. This is our review session, so we will review the exam, the practice exam. If you want to review along with us, that's great. I have images to go along with the answer key. The answer key is posted on Moodle already, so you're welcome to grade your exam. Remember, for these practice exams, we're still in the first kind of 2 weeks of our high yield study prior to NPLEX, so we're looking for scores above 70% are an indication of passing or likely to pass this section. Scores between 60 to 70% on these type of exams mean you're on the right track. Keep up what you're doing, and over the next kind of 2 to 3 weeks, we expect you to get above that 70%. If you're below 60% when you grade your exam, that's okay. It just means that we have some work to do, probably transitioning from lower or moderate yield study to more high yield study, repetition, practice questions, memorization, fill in the blanks, etc. So that's really kind of what these practice tests can help indicate. I would say in comparison, last week's practice test for biochem was more challenging overall than this week's practice test for anatomy is overall. So this week's practice test for anatomy may be a little bit not easy, but on the easier side of an NPLEX-like questions, versus the biochem last week was more challenging. To give some perspective. So if you felt like this exam went through, you're like, oh, I got this, there could be more challenging questions on the NPLEX, of course, than the ones that we put, but this is about an average of what you could expect. So I'm going to share my screen, and what I have essentially, and I'm recording this session, you can see all of your faces, and I haven't posted this yet. This is like my review of the exam, and it contains images, it contains my notes or comments. So I will post this after we've read it together. So you'll have access to this. Currently on Moodle, all you have access to is just a base key that just has the correct answer in bold. Before we get into kind of going through these questions and these pieces together, how did the anatomy portion feel, at least what you could get through?
I feel like overall it was kind of nice to take after the biochem because, like you said, it was not quite as challenging. And I feel like anatomy I'm a little bit stronger in and I feel more confident in. So overall, I think I feel pretty comfortable and pretty good about where I'm at. And like I know there are topics to review, but this kind of gave me direction to is like, okay, make sure to review these things. Or, oh, I didn't think to go over this, so I'll make sure I add it to the list.
That's great. Awesome. What did other people think?
I thought the same as Danielle. It was definitely easier than a biochem. Anatomy wasn't my strongest on the actual NPLEX, but these questions felt easier than the NPLEX questions. So I think you're accurate that this is kind of like an average of what you could expect.
Yeah. Yeah, you're gonna find more hard and then some softer, easier questions on the exam. My intent is to post kind of a secondary follow-up anatomy exam. It's a little bit more challenging after we go through the review, so you could self-take that on your own as well. So I'll post that to the Moodle page. I really just wanted to give us an overview. This goes through, top to bottom. There's about 4 to 5 questions per organ system plus embryology from this test. So this is really kind of a top to bottom, head to toe exam from actually the textbook that you use in medical school, which is our medical physiology textbook, Goyden and Hall. So that's where these questions were derived from, was their questions, and then some NPLEX questions kind of combined together. So it's a good comprehensive exam of what you could expect for medicine. So I'm happy that we felt okay about it. If you didn't feel okay about it, that's okay. That's what we're here for. So I'll just kind of go through, and then we'll just walk through a couple pieces, and I'll highlight stuff that I think is important, and then things that are relatively straightforward, I'll probably move through relatively quickly so we can get through as much as we can in this last hour tonight. And then we'll finish up probably the last 30 questions we'll get to tomorrow morning as we get into our day. So we'll probably be able to get through about like questions 1 through 70, I think, in the next like 48 minutes. Okay. As I go through, if you have questions or it's not clear, just like talk. You can speak over me. It's totally fine. This is very casual. So speak over me if you need to raise your hand, if that makes it feel more comfortable, great. But I'm just gonna fly through, so feel free to interrupt as I'm going. So our first question was talking about cavities and spaces in the body. So our thoracic cavity, as we remember, contains what organs? Heart and lung, and it's found in which portion in relevation or relevance to the vertebral cavity? It's anterior, and it is housed actually in this whole ventral body cavity. Within it, you can see you have your left and right pleural cavities. You have your pericardial cavity within the mediastinum, and then this kind of diaphragm as your biomarker, your marker. This is your reminder too, if you haven't looked at your cavities, to remember the cavities of the body, right? Thoracic, vertebral, and the ventral body cavity, your abdominopelvic cavities, know what organs are housed in each, and kind of the areas that would delineate those different cavities or spaces. Not a lot of questions derived from here, but it is a good place, especially if there's a question about a person had an accident and they had an injury to this cavity, what organs could be affected? That's how I could see these questions being asked on NPLEX. We know that veins and arteries, we're going to review all of our veins and arteries tomorrow, the high yield ones, and practice drawing them out together. So that's going to be a component of our review tomorrow. But especially the arteries and the veins that have pathologic significance or physiologic significance. So anything that you can take a pulse, knowing like where it is in the body and potentially what it's feeding to or what fed into it will be helpful. So for our arteries and veins of the leg, this was asking about our popliteal pulse point. And so we know when we palpate that, we can feel it behind the knee. But knowing also the popliteal artery's relationship to our tibial and our peroneal arteries, the dorsalis pedis, and then also the posterior tib, which isn't represented on this image here. And all of these came off of the femoral artery up top. So kind of being able to trace these pieces down and then knowing the pulse points would be helpful at the start. And then also we can't forget about the veins. So moving up, we have our dorsal venous arch, our small and our great saphenous veins. These superficial perforating veins, these are your varicose veins typically, the femoral vein, and then your external iliac vein. These are probably the most important arteries and veins. Obviously, there's much more. But if you have a minimum to learn, these would be my minimum to go through. If you're struggling with the venous system, I would encourage you to work on drawing them out. So start with like a large structure, like the external iliac vein, or even start at the abdominal aorta and then draw downward. We will do that for the heart tomorrow, the aortic arch, and the brain, circle of Willis, and the abdominal aorta and its offshoots for sure. We'll go through those tomorrow, and we may have a few others that we'll have time to draw out. If not, we'll have pictures or images to go through. So those will be pieces to review, but anatomy for veins and arteries is huge on NPLEX. Basic naming, where's the joint found, what region in the body? This is coaxial joint, it is your hip joint. So it's just, again, a clean name recognition for this one. Really nothing else from that. Again, another medial cubital vein, so be able to identify where this vein is. Anterior side of the elbow is where you'd find it. So what does that look like? So medial cubital vein is this one here. We can see it's going to lead up into our basalic vein. The brachial vein is in a different system. They're both going to combine together up here and to become the axillary vein, which has an offshoot to go to the subscapular. The cephalic vein is going to move down here and it separates into two branch points and actually will branch back together with this system down below in the forearm. And then all of these come off of the subclavian. The best kind of NPLEX questions for, again, venous or arterial system is something happens up here, what flow would be affected down here, or vice versa. Something happens here, what could be affected up north, up above, more proximal. So knowing the relationships between the two and generally where they're located is helpful. We often learn arteries and forget about the veins. So this is my plug. Don't forget about the veins. They're important too. Okay. So now some histology, right? Because histology counts as anatomy unless if they're asking about function. So what are the following structures would aid in a cell allowing more nutrients to be absorbed by the cell? We have stereocilia, microvilli, primary cilia, or flagella. Microvilli is our increaser in surface area. That is its job to cause an increase in surface area so we can increase absorption. versus stereocilia is actually a sensory epithelia of the inner ear. So it's a specific organ function for sensory. The primary cilia is the cilia we think of in our respiratory tract that does the sweeping motion to help move particulates up and out of our respiratory system, our conduction zone. And then flagella, think movement like tail on a cell. So bacteria or sperm. That's like what I want you to think of when you think of flagella. Another kind of great histology question I see often is about our different components that can hold cells together. So anytime you hear this question asking or involving tissue, I want you to think desmosome. So is there a tear of the tissue? Is there issues with tissue structural integrity? If there's anything wrong with the tissue, think desmosome as the connection point, because that's what actually is creating a tissue. It's holding these cells together in tandem, and it holds tension. So if you have breakdown or destruction of tissue, you could have destruction of desmosomes. And we see this with certain conditions, specifically some skin conditions, where we actually see tissue breaking apart. It's because desmosomes are being destroyed. So when you think tissue, think desmosomes. When you think pores, like ion transport, this could be in our axon. This could be in our cardiac cells. We think about this probably the most in the cardiovascular system. But gap junctions are your portals or your pores that allow for ions to flow from one cell to another without having to leave the cell. They can flow directly through these pores for ion transport. Connexins are a type of gap junction. So these are a specific type of gap junction. They are also a pore, allowing things to move from one cell to the next. And then a tight junction creates our apical and basal layer. We could also say a tight junction creates cellular polarity. It's going to separate, essentially creating an intraluminal space or an apical space and a inside the body or a more deeper space, the basal space. And it does that by holding cells together, not as a tissue, but preventing ion leakage between the cells. Preventing that, I guess you could say, was it trans or paracellular transport? I think it's para, I'd have to look it up. But essentially preventing transport of ions between cells. So tight junctions keeps the cells tight together. Okay. An inclusion, not an organelle. This is just terms. Essentially, inclusion could be a pigment, a molecule, a compound, but doesn't have a specific intracellular function. So melanin is a pigment, so it is an inclusion in this instance. Lysosomes are an actual organelle. We'll look at them here in a moment, actually, and it contains lysozyme. Lysozyme could be called or considered its inclusion. So if lysozyme was listed and melanin, then you would have a tougher time. If it was melanocytes and lysozymes, well, melanocytes are a whole cell, right? So that wouldn't count as an inclusion either. So it wouldn't count as really either of those pieces. Microtubules are our structural integrity elements of our extraskeletal system, but they are considered organelles as a part of the part of the actual cytoskeleton, and they're made of collagen. And then cilia is that external structure on a cell. It is an outside appendage, but it is not an inclusion. It's not considered an inclusion body or an inclusion portion of the cell. It would be considered an organelle as well. It has a specific function. So the only one that's different than the others is melanin. Okay. We could put in here lysozyme. We could put in here really anything that's intracellular that is pigment-based or molecular-based that's not organelles. I'm trying to think of another good example. Can't think of one off the top of my head, but there are others. But really, organelles, you're looking for that functionality within your cell. So then speaking of organelles, we have processing and packaging proteins, which organelle does that for export from the cell. The kicker here in this question was processing and packaging. That's probably like your key piece, because technically the endoplasmic reticulum and Golgi apparatus can process. Endoplasmic reticulum typically is doing more protein remodeling, like playing around with tertiary and quaternary structure of proteins. But they both can do processing, the Golgi and the endo. What the endoplasmic reticulum cannot do is it cannot package proteins or really anything into secretory vesicles to leave the cell. That is specifically a Golgi apparatus process. So because they have the and packaging of proteins, that's why the Golgi is the correct answer. Versus endoplasmic reticulum, if they just said processing and not packaging, then endoplasmic reticulum could be a good choice. Lysozymes and peroxisomes, I have kind of a little comparison here because they both are breaking stuff down. They're both membrane-bound sacs. They both can form digestive function, meaning breaking down pieces. Lysozymes can have enzymes, or lysosomes have lysozymes, which are enzymes that break down food, waste, bacteria, and even old organelles. The enzymes in peroxisomes are oxidases, and they're really for our like oxidize, or they're catalyzing our redox reactions, and they're helping support that reactive oxygen species process. So our peroxisomes have oxidases catalyzing redox reactions. There's lots of peroxisomes in our liver to help break down alcohols. They bud off from the endoplasmic reticulum versus lysozymes bud off from the Golgi apparatus. So two different sourcing as well for these very similarly related organelles. Okay. I'm gonna do two more and then check the pulse and how we're doing. So our myocardium rhythmically contracts, we know that. So what's the organelle that's going to produce the most energy? Our mitochondria. It's going to be our energy producer via aerobic respiration. Smooth endoplasmic, processing and folding, lysosomes, breaking down of stuff, cytoskeleton, keeping our skeletal structure. So mitochondria is the best answer here. How else could this be asked? You could see potentially what cell type does not contain mitochondria is in more of like almost an anatomy to a biochemistry question. And then your answer would be erythrocytes or red blood cells. They do not have mitochondria, so they have to undergo anaerobic glycolysis. All right, and then last one before we check a pulse. Which of the following is a modification of simple columnar epithelium that allows for efficient absorption along portions of the digestive tract? And the kicker here is what's the mod that could be done to this type of epithelium, and then what type of epithelium is found in the digestive tract. So those are kind of like your key words here. Dense microvilli is your classic presentation, specifically in the small intestine. It's your brush border, right? It increases surface area. It allows for more absorption. Thin and permeable, I want you to think of the really thin layer that makes up the respiratory membranes, allowing for diffusion of oxygen and carbon dioxide without much resistance. Fibroblasts are creating fibers, like collagen-based typically for structural support, so that's not involved here. And then cilia, we've mentioned, involving in actually helping remove particulates that get into the pharynx and the upper respiratory tract structures. So this is our best answer in regards to the digestive tract. Okay, so a pause. That was 1 through 10. How are we doing so far? Doing so far so good? Okay, speed okay that I'm going through? Yeah, speed okay that I'm going through? Okay. I was like, if I speed up too much more, I'll just be talking over myself. So if I need to slow down, let me know. But I do want to at least kind of give some perspective to how we could go through these questions. So I'll keep it going. We'll get through the next 10 and I'll check the pulse again. We'll see if we're all awake on this Friday evening, anticipating snow. Okay, all right. So a ciliated version of pseudostratified columnar epithelium containing mucus-secreting goblet cells, and it's like asking you where it would be found or what it helps to do. So kickers here is pseudostratified, right, which means single layer of cells that look like there's multiple layers because they're different sizes. Columnar in columns, and then epithelium, the type of tissue that we're talking about. So this is our tissue type, epithelium. And then our mucus-secreting goblet cells. So we could go to where are these found? They're found in a couple different places. We could go to where is this found? This is found in less places. So of these answers, the respiratory tract is your best answer because pseudostratified columnar epithelium is going to line from your pharynx down into your primary bronchioles, down all the way till it gets to almost your tertiary bronchioles, where then the columnar epithelium, it moves from pseudostratified to just straight columnar. And then once we get into the respiratory zone, close to our alveoli and our sacs, those terminal regions, we're now cuboidal, cuboidal epithelium. So we transition in our respiratory tract from here in our larger bronchial structures to being pseudostratified columnar. Then we move to just columnar, and then we move to cuboidal. So it's kind of our transition through our respiratory tract. Anytime we're thinking about digestion, think microvilli, simple columnar cells. That's going to be your epithelial lining almost always. The most durable epithelia would be the one with the most layers. So if we have anything that's truly stratified, like a stratified squamous epithelium, that's going to be more durable because there's multiple layers. Think the skin, right? Our top layer of our skin, our stratum cornea or stratum corneum. And then found in some of the larger glands, almost every gland in the body is lined by simple cuboidal epithelium. Because it needs to contain, those cells need to contain the space to create those secretions that are then secreted via the glands. So we can't have flat cells. We don't have super tall cells. There's no reason for that. And we don't want multiple layers. So simple cuboidal is what we're left with. Transitional we'll find in the bladder. That's the main space we'll see transitional epithelium because the bladder is going to expand and, expand and then contract. All right. Which of the following epithelia forms the walls of air sacs? So I kind of mentioned this already, our alveoli, where gas exchange occurs. This is going to be our simple squamous because it's the easiest to diffuse oxygen and carbon dioxide down their pressure gradient. And the specific cell type in these alveoli that makes this lining are type 1 alveoli cells versus type 2 alveoli cells are creating surfactant. So that's a key distinguisher between those cells in the alveoli themselves. Type 1 they equal the same. They are the simple squamous epithelium of the alveoli. And then I kind of reminded us where we find these other pieces. Looking then at what type of connective tissue, so moving from epithelial tissue to connective tissue, our four different primary tissue types. What type of connective tissue serves as universal packing material between other tissues? I mean, when you're thinking of what types of connective tissue, anytime you hear packing material or structural support, think connective tissue proper. And then we're thinking, is the tissue going to be more dense? Or is the tissue going to be more light and flowy? It's going to depend on its function. And so if it's more light and flowy, like it needs to be able to fit in lots of different places, we think packing material, soft, something that's softer. Areolar connective tissue is going to be your best bet because areolar connective tissue has the most ground substance, liquid, and the least amount of fibers. So it's going to be able to fit between all those different spaces in the body versus a reticular connective tissue or a hyaline connective tissue is a more dense connective tissue that contains more fibers. Reticular, kind of like a web, spider web. So it have a little bit of flex, but it's really good at covering like spaces that it needs to cover in multiple different directions. Hyalin's typically having like a one directional pull. It could be pulling from multiple directions, but it's really strong collagen fibers that make up our hyaline cartilage, right? And then adipose is another type of connective tissue proper. It is going to be more squishy, but it's not our universal packing material between other cells. This could be our, I would call this more energy storage or our fatty cell storage or our fat storage. It could be insulation. That would be a way to refer to it to help with heat maintenance, but typically not packing material. That's not how we'll hear it stated. A key piece with connective tissue is there are multiple types of connective tissue: bone, blood, cartilage, and connective tissue proper. So connective tissue as a tissue type includes blood, bone, cartilage, and connective tissue proper. Connective tissue proper including things like adipose, areolar connective tissue, reticular connective tissue, dense connective tissue, elastic connective tissue. All of those would count as connective tissue proper versus cartilage is in itself its own category on its own. Bone, obviously same, and blood is the only fluid form of connective tissue. All right.
Dr. Petra, I have to log off for now, but I will be back tomorrow morning.
See you at 9. Thank
Yeah.
you. Yeah,
Okay,
go eat some dinner. Bye.
Okay, bye.
Awesome. Then looking over here, a substance received or given off by your body will pass through what tissue type? Anything that we're thinking that's going to be received or given off, we're thinking has to diffuse. And our tissue that cells or things diffuse through is going to be epithelial tissue, because epithelial tissue is going to be lining all of our tubules. So I often think of kidney tubules or the GI tract. Those are both going to be epithelial tissue structures. Our connective tissue is more structural support or storage. Nervous tissue, neurons, neuroglial cells, axons, and then muscle tissue, we think cardiac, smooth, and skeletal, doing some type of work or action. So this is the best answer, the liner of all of our glands and all of the lumen of the body. We then go into a gland question. Glands like the thyroid secrete their products directly in the blood rather than through ducts. And this classifies them as endocrine glands, which are hormonal circulatory secretion. So endocrine glands secrete things into the circulatory system. Exocrine glands have local secretion. We think about all of our gut digestive juice glands, all the glands in the stomach, or even the pancreas. Sebaceous are local secretion dermatologic glands secreting sebum to the skin, creating an acidic, oily layer, preventing water from getting in and leaving. And then ceremonous is actually cerumen glands in the ear. And so it looks like cerumen, it is cerumen, but it's also local secretion, not systemic. So endocrine's the only one that meets that piece. This is a classic NPLEX question. A needle would pierce the epidermal layers of the forearm in which order? Crying little girls spray boogers. That's my mnemonic that I've remembered my whole life for the layers of the skin. So your corneum, your lucidum, your granulosum, your spinosum, and your basal or basale. I'm sure you could come up with a more mature acronym. This is just the one that stuck for me. So corneum being the most superficial and then moving inward. Lucidum, the L, is only present in thick skin, so it may not always be included in your answer selection, but all the other four should be, and then they should be in this order, moving from external to internal. If they ask you a question like, I don't know, something going in the opposite direction, being able to work in both directions would be important. Almost always, though, they ask it from external to internal, because that's the needle puncturing through. That's like the classic NPLEX question for these layers of the epidermis. Come grab some beer. I love that. That's even better. Awesome. Thanks, Gigi. Come grab some beer. Yep. Works. Perfect. All right. Then we get into a random question about hair shafts. They don't ask a lot about hair, nails, but they could. So this is just clarifying what are the regions of the hair shaft versus the root. So the one that is not is the external root sheath. If we look at hair, we can see that the shaft is once it's left this root region being associated by this green inner root sheath. So the hair shaft has three regions, the medulla, the cortex, and the cuticle. Versus if we go more inner, we can see we have this green inner root sheath, this tan outer root sheath, and then we get the hair matrix and the hair papilla, which actually is sourcing the bulb with nutrients needed to help grow. Our sebaceous glands associated and our erector pili muscle that helps our hair stand on end. But that was the kicker, is identifying the shaft as in the question and knowing that those three pieces, medulla, cortex, cuticle, make up the shaft, versus the root sheaths are not involved in the shaft. The shaft doesn't include the root. That one I've seen used just because it's all of these but one, right? They love those type of questions. This is another skin layer question. A splinter penetrated into the skin of the sole of the foot to the papillary region of the dermis. What layer of epidermis would be the final layer injured? If you know your come drink beer, whatever acronym you use, you'll remember that basale is the deepest layer. That'll be the final layer before the basement membrane, and then moving to the papillary dermis, which is the first layer of the dermis. That feeds into this next question. The dermis has the papillary layer, which is the most superficial layer, and it's made up of areolar connective tissue, and the reticular layer, which is the deeper layer, and it's responsible for tension lines in the skin because it has all that connective tissue present. There's then the subcutaneous or hypodermal layer, which are meaning the same thing. They're both the fatty layers, and they're not consistent with, they actually not considered dermal tissue. So if asked, the hypodermal or subcutaneous layers are not considered dermal or dermis tissue. The reticular layer is the correct answer here. Papillary layer would be more superficial. And then you have the last question on, where actually we'll finish out these questions about tissues. So the structure of bones, it's the function. This is asking about different types of bone tissues adapted to support weight and withstand torsion stress. The more stronger bone is going to be compact bone. Of note, compact bone lines all of your flat bones. It lines the shaft and the ends of your long bones. It lines irregular bones. It lines your small bones, like in your hand. So compact bone is involved really with all bones that we have. It's just the percentage of compact bone to either spongy or trabecular bone, which we could use these interchangeably. These are the porous bone, and both spongy and trabecular bone will be filled up with red bone marrow versus the shaft of a long bone in adults will not have red bone marrow unless in pathologic states. In fact, in adults, the shaft of long bones will contain yellow marrow, which is used as fat storage and heat generation. The only reason that will change is if there's an adult who's anemic or has low blood counts for whatever reason, then the shaft of the long bone, that yellow marrow, can convert back to red marrow and participate in hematopoiesis until there's an adequate amount of red blood cells again. So we can have a conversion, but typically adults, our long bones have yellow marrow. All of our spongy and trabecular bone throughout the body will contain red marrow, and that's where we're doing our hematopoiesis, our red blood cell creation. In fetus or infants, there's red marrow in the long bones. So that's different in developing bone. As we'll see here, our long bones in the embryo are made up of our hyaline cartilage. So this is a great NPLEX embryology question, asking you a tissue and a kind of developmental question. So we create almost all of our skeletal system as a developing embryo to fetus is hyaline cartilage, and then we remodel that in development to create bone. And this is kind of the process here. We'll look at this process briefly tomorrow at the end of our day together. We'll go through a couple high-yield embryologic processes, as well as the germ layer tissues, the 3 germ layer tissues. If you break the shaft of the bone, asking specifically what portions would you break, so your epiphysis, metaphysis, diaphysis, and articular cartilage, we can see here that the shaft of the bone is considered the diaphysis. So this long portion here, the metaphysis is considered typically where the growth line or the growth plate would be. And then our epiphysis is going to be the end of that bone. Both the metaphysis and the epiphysis, hard to say 3 times fast, contain spongy bone or trabecular bone. So I'll have red marrow. The diaphysis is your shaft, so it's hollow. Compact bone surrounds it, and inside will be yellow bone marrow in adults. Some bone marking questions. I often see these asked more in association with naming or figuring out what's going through what. But if they ask you a direct question, it's good to at least know what these things are. So the question was a round or oval opening through a bone, that's a foramen, versus a meatus is a tube-like canal. So the difference being both are going through bone. The meatus is going to be longer, a longer tube that something has to travel through. Think like auditory canal, versus a foramen is just a smaller, thinner opening. Both are holes though. Both are moving through the bone. One is a tunnel, meatus. One is just a window, an opening, foramen. Fossa is a cavity. Epicondyle is a bony projection, and ramus is an angle that often has a joint. We think of our rami of our mandible. If we're going to obtain bone marrow, we're going to look for places that have actual red marrow present. Frontal bone, hip bone, head of humerus, and the medullary cavity of the femur all technically would have marrow in them. But the classic sites for a bone marrow sample, because they ask this, are places that have red marrow and are more superficial, easy to access. So our iliac crest, so our hip, the sternum, and then the tibia. So if they gave any of those answers, those would be the ones we choose. They gave hip bone, so that's appropriate. If they had hip bone and sternum, I probably would have chose sternum over hip bone, but technically both are correct. Both are the most, all four of these technically are the most common places they'll harvest bone marrow, red bone marrow in a patient. Okay. Our sphenoid bone is the keystone of the skull. I have it here. This, if you're gonna like focus on knowing one bone of the head, more particular, the sphenoid would probably be the most high yield. Maybe ethmoid after, but I think sphenoid, because it has so many different structures, it's so unique looking. It's right smack dab in the center of the skull, and it articulates with all the other bones of the skull outside of the mandible. It also contains the optic canal, the foramen rotundum, the superior orbital fissure, the foramen ovale, and the foramen spinosum. So identifying two, we'll look at this tomorrow when we look at cranial nerve or CNS anatomy. What are the things that go through these holes? Knowing those associations is really helpful for patient fractured their skull and they broke off the lesser wing of their sphenoid bone on the left. What structure could be affected? So those type of questions, those next level questions are what we'll get to tomorrow during our review. This is where they articulate, so you can kind of see by color. I like the color form. So the frontal, you see the parietal, I think this is our sphenoid here, occipital, zygomatic, ethmoid, and then temporal, we can see. Another sphenoid bone question. So the sella turcica, this has been on NPLEX multiple times, is part of what bone? It's part of the sphenoid, and it houses what gland? It houses the pituitary. And so this is what the sella turcica looks like. It's the circular portion here, and you can see that the pituitary gland, the anterior and posterior portions just sit right inside of it. Hanging down its infundibulum from, I don't know if we can really see it in this picture, but we will in another picture, the hypothalamus. Optic chiasm is right above here, and I don't know if there's anything super exciting. Oh, this is kind of showing this is the start of the brainstem. But this is a classic NPLEX question because there's so much importance with the pituitary gland that they'll often want you to make that association. So sphenoid, sella turcica, pituitary gland. Those would be your three kind of associators to keep those three together. Okay. Now it's asking about the relationship with the hypothalamus. It talks about how the hypothalamus is superior to the pituitary. So then they're saying, well, if the hypothalamus is superior to the pituitary, it's what in relationship to these other structures. So if you know that the hypothalamus or the hypothalamus is superior to the pituitary, you know the pituitary sits in the sella turcica. You can see this question here being quite easy to answer. Your hypothalamus is here, optic chiasm, your infundibulum, anterior, posterior pituitary, the hypophyseal fossa, and then sella turcica of your sphenoid bone. Now, obviously, if you didn't have that right in your brain, you would, if you knew where any of these other structures were, you would do your process of elimination. Obviously, this one here, because we talk about the hypothalamus, we can rule it out. The only region of the brain that's outside of the skull, we know that's not true. So we can cross out this portion, and then you're just left with a cristogali and cribriform plate. So depending on where these structures are, you could then try to process of eliminate, knowing your knowledge about hypothalamus and pituitary gland. A vertebral question, if they're going to ask about vertebra, they'll ask probably about transverse processes in the cervical vertebra. They'll ask about costal facets or facet joints in your thoracics, or they'll ask about your axis and your atlas. So knowing that your atlas is C1 and it is the only vertebra to not have a, the atlas is C1 is your only vertebra to not have a body. Your axis is C2 and you can see has a body right here. So our axis, the exciting piece about this, no body, the skull is sitting right on top of it. It has this space, this hole in the center for that will house our odontoid process. And it kind of has this posterior portion, but really no like spinous processes. Versus our axis, C2 has this odontoid process that articulates here with our atlas and allows for that rotational component. So our head can swivel. This is just correctly matching type of joint with function. So I have all of your functions here, your ball and socket joint, your pivot joint, your hinge joints. Your wrist is considered a saddle joint between the like actual carpal bones versus your radius and carpal bones of your wrist. Your like true wrist joint is considered a condyloid joint. So saddle joint versus condyloid joint. And then your tarsal bones, we consider this a plain joint because there's not a lot of movement that really happens here. So we look at our question, we had wrist, saddle. Well, wrist is going to be condyloid. Carpal is saddle. So that one's tricky because it's close. Ankle, hinge. We can see our ankle joints here. We know we can do dorsal flexion and plantar flexion. We can do a little eversion and inversion. It is actually going to be a hinge joint like our knee and like our elbow. And then elbow pivot joint, that's wrong. There's no pivoting in the elbow outside of a little supination and pronation. That's not really the elbow. It's more of our muscles. And then interphalangeal plane. We know that a plane joint here, located here, our interphalangeal, we're able to actually flex and extend. So that is not the correct joint association. So being able to just put where your different joints are, depending on those motions of the body, could be helpful. I think actions are asked about more in joints than anything and in relationship to muscles, but they could ask you a direct kind of anatomical joint question like this.
Dr. Petschel, I have a quick question.
Please.
For vertebral and sternum, like ribs, what are those? Well, for vertebral, would they be considered plain joint, like planar joints, or what? How would we classify those?
For like, yeah, for our vertebral and our wrist. Well, so wrist we do condyloid. But for our ribs, that's a good question. Let's circle back because I want to look and see. I would like to say plain, but I also feel saddle could fit really well there, maybe. So I feel like it would be one of these two, but I would want to look. So let's look.
Okay.
Yeah.
Cool.
Yeah.
Thank you.
Yeah. I will look into it and then I will make sure I post a guide tomorrow that has them all on there. Yeah. All right. Few more and then we'll call it a night because we're 10 till. Can you believe it? We've just like flown through and then I'll post this online. Moving your jaw forward, causing an underbite is protraction. I have a natural underbite, so I can't really protract more. And then pulling it backward is retraction, pulling your jaw backward. You can also protract and retract your scapula, right? So that's the other one that you can really think about, protracting and retracting. Pronation and supination. Supination, you're holding a cup of soup. Pronation, it's like you're doing a thumbs down. That's your pronation. And then adduction, you're adding back towards your body. Abduction, you're going away from your body. I think those are the most confusing joint movements or like movements that could happen at a joint. Most of the other ones are relatively straightforward. Jumping jacks, so if they give you an action, like what are you doing? You're abducting and then you're adducting. You're abducting away, you're adducting back, out and back. Flexion and extension, you're flexing, you're extending. Supination, pronation, right? And then inversion and eversion, specific to the ankle. Inversion, you roll on the outside of your foot. Eversion, you roll on the inside of your foot. And inversion sprain is the most common because it's much easier to roll your feet to the outside than it is to roll your feet to the inside. A little bit of muscle now. We've moved out of bone tissue, so we're into our third type of tissue, which is muscle. And so with our muscle tissue, we have this horribly wonderful picture of a sarcomere with our thin and thick filaments, thick filament being myosin, thin filament being actin. When we're looking at this picture here, the question is when a sarcomere contracts, so when these ends get shortened. That's contraction, right? Muscle gets shortened. Thin filaments move over thick filaments. You would expect to see what? So looking at these bands here, the first one is eye bands appear smaller. The unit shortens. And that is correct. Eye band is this section here where there's no crossover between our myosin and our actin. So this eye band is these portions on either end. When we're actually essentially ratcheting down the sarcomere closer together, we can see there's pretty much full crossover. So these eye bands appear smaller. They do. They get smaller. They get thinner. That is classic, showing that there's shortening of our sarcomere unit. Our H zone, this is the portion in the center that separates our thin filaments from one another. It shows that there's some separation between the two. It does not get wider in contraction. It actually almost goes away. We just have the M line, the M midline line. Our I bands don't get wider, they get smaller. And then our A band, this is actually from one I band to the next, is called the A band. They say the A band appears darker, which isn't in fact true. There's no color change to the A band. Where there is a color change, there's a slight change in the middle in the H zone, but there's no color change to the A band. So that is your kind of sarcomere contracting. I think this picture is probably the easiest to just get an idea of what's happening here, this process. So our oxygen-starved tissues release signals telling the body that we need oxygen and nutrients places. The blood vessels then vasodilate to make themselves bigger. And the question was, what's the muscle involved? It is smooth muscle, which is present in arteries. Cardiac muscle is not in arteries, only in the heart. Skeletal muscle is voluntary, and striated is both skeletal and cardiac muscle. So it would not work here. So smooth is your best answer. All right. I'll see if I can get through the rest of muscles. Then there's the question about considering muscles, what's true? Cardiac muscles have many nuclei. That's not true. Only skeletal muscles have multiple nuclei. Smooth muscle cells have T-tubules. Not true. Cardiac and skeletal muscles have T-tubules because there are these invaginations into the muscle cell to reach all these individual sarcomere contractile units. Our smooth muscles, remember, they contract kind of by like twisting. They have all these fibers connected almost like a web, and then they pull together at the same time, and it's like you're wringing out like a sponge. That's what your smooth muscle is doing for contraction versus actually shortening as a whole. Striated muscle cells are long and cylindrical with multiple nuclei. That is true. And then cardiac muscle cells are found in the heart and large blood vessels, not in large blood vessels. This is a great NPLEX question because technically how they've stated this is almost wrong, right? They said striated muscle cells, and with that statement, they've included cardiac because cardiac muscle cells are striated. And we've just had to say that they don't have many nuclei if we disagree with this statement. So it is kind of a misnomer, but this is the one true correct statement. It would be better stated skeletal striated muscle cells. That would be the best correct answer, right? But they don't. They just say striated muscle cells. Yay, NPLEX. What muscle extends the great toe? A typical action. I always say with your muscles, if you know your action and general location first, great. If you can then add in an innervation, then you should be good to go for your MSK portion. I do not encourage you memorizing origin and insertion. So our extensor hallucis longus is going to be extending our big toe. We can see this muscle coming down here with its tendon innervating at that big toe. This also showing the soleus. We have our gastrocnemius in the back, our flexor digitorum longus, our extensor reticularum, our fibularis tertius. That was one of the questions. It's going to be on the opposite side, right? So the lateral side. And then extensor digitorum longus, it's going to innervate on our other toes. The other muscle they gave us was the tibialis anterior. That's our shin muscle, right? So it's not going to have the same action as the extensor hallucis longus. Okay. Great. Awesome. Another great kind of muscle area that we'll look at tomorrow is the muscles of the rotator cuff. But the question is, who is the synergist of the latissimus dorsi, who extends, moves backward, medially rotates, so rotating inward, and it adducts the humerus, so kind of the arm behind your back position. And it in fact is the teres major. So if we look at where these muscles are, we don't have the latissimus, the latissimus dorsi is here. And then we have our teres major, which is literally right above, and it's innervating almost, or it's attaching almost at the same attachment point. So it makes sense that these are going to be working in tandem together as a synergist, causing these actions to occur simultaneously. Teres minor attaches at a different point, is much smaller. Infraspinatus is on our scapula. Supraspinatus is here. They just removed it. And subscapularis is on front of the scapula. All involved in our rotator cuff, those three, but not involved in this extension, medial rotation, and abduction of the arm. So again, this is just actions. If you know your actions of your muscle, you'll be able to walk through a lot of your MSK questions, which there won't be tons. Who's your chewing muscle? The masseter is the biggest. If you had to choose another one, I would choose the temporalis as your second. All these other muscles are smaller players or smaller factors in the face, but the masseter is absolutely the one in charge for mastication. So that is your big muscle of mastication, is your masseter, and it's innervated by the mandibular branch of cranial nerve 5. So that trigeminal nerve, the mandibular branch, innervates your masseter. Then your mandibular nerve, cranial nerve 5, also innervates your temporalis. Well, no. Yeah, same. That's why you can test it by clenching your jaw. Tightness in the neck and draws the corners of the mouth downward, expressing horror as your platysma muscle. When you think of it as like the superficial muscle here, your SCM, your sternocleidomastoid, are these like actual big tendons that you often use as a hallmark to find your carotid pulse. What else do they have? Mentalis. Mentalis is your muscles with your chin. I don't think they even they don't even label them here. You put your little mentalis muscle. Wait, no, sorry. Yeah. And then what was the last one? Sternohyoid. I don't know if they have that labeled. We don't have that labeled on here. So I can get a picture that shows this tomorrow. But platysma and SCM are often asked about because they're kind of these muscles that are closely related here. I would also put in this category your scalenes, because your scalenes are accessory muscles of respiration. So they have more of a function besides just facial expression. Okay, we'll stop here for now because it's 8 o'clock, if you believe it. Oh my gosh, so much talking from me. Gross. So what I'll do is we'll have time to do a little review tomorrow morning. So we'll go through like 20 questions in the morning, and then we'll get into content, do some activities and some fun. So when we wake up, you can kind of like listen and zone for the first half of the hour, and then I'll make you do stuff the second half as we get into our day. And then we'll wrap up the review at the end of the day. So we'll kind of blanket both days with kind of some review on this test that you took. But throughout the whole day tomorrow, we'll follow our schedule. So I have that schedule posted online. I have one tweak I have to make to it, and then it'll be good. And I'll post all the content for you, so I have access to everything before the get-go at 9 a.m. It's all hidden, so I'll make it live. Okay. Tomorrow, I encourage you to have paper and like markers or crayons or pens or whatever you like to doodle or color with, because we will be doing some like drawing out activities. So if you have something like that, have that ready for you, because that will help you walk through these exercises. Great. Stay warm. Thank you for being here. Good luck on your studies. Don't study anymore tonight. Okay.
Thank you so much, Dr. Petshow. It's really incredible that you do this for us, really.
Oh,
Thank
thanks.
you.
I love
Yeah.
it. Well, I hope
Agreed.
it gives us like you feel like at least you have a buddy as you're going through this study. So that's sorry, I muted myself. That's the goal. Awesome.
Yes,
Thank you.
so much.
Thank you
course.
so much. See you tomorrow.
Thanks, Gigi.
Thanks.
Yeah, I'll see you all tomorrow.
Good night.
Stay safe.
You too.